got nothing to offer, but it's been really amazing to see how this field has evolved and developed. We have so many wonderful procedures to offer patients with congenital and acquired structural heart disease that historically had to be treated with open cardiac surgical procedures.
I'm going to turn the volume off here and have you speak on the computer because now it's echoing off of it. So apologies.
No worries. Tech problems.
We will get this right.
Anyway, it's been really amazing to see how far we have come. Let's see if the next slide works. Yes. So this I put in this slide for the purpose of history and for the fellows. Does anyone know who this is? This is Claude Bernard. He was a French physiologist who was actually the first person to do a heart catheterization where he cannulated the carotid artery and vein of a horse, 1844. Only he got no credit for that. It was this man here, Werner Forssmann, in 1929 in Eberswald, Germany, who actually did the first cardiac catheterization on his own arm when he incised his basilic vein and inserted a urinary catheter and went down to radiology. And this is his x-ray showing that the urinary catheter did indeed go all the way to the heart. And he opened the door for invasive cardiology. He did this to himself 6 more times. He was ridiculed by his partners and eventually gave it up and became a urologist, but won the Nobel Prize in 1954. For this simple discovery. And does anyone know who this is? This is really a giant of modern medicine. This is Sven Seldinger. Sven Seldinger, think about his invention, the hollow needle with a wire that allows you to gain vascular access. The entire field of invasive cardiology, indeed electrophysiology as well, is based on our ability to access a vessel with a hollow needle and put a wire in and put an introducer sheath. He developed this technique, Seldinger technique. Sven, he was a Swedish radiologist. And then this is Mason Sones. Mason Sones is a pediatric cardiologist at Cleveland Clinic. And he was doing a cardiac catheterization on a 26-year-old with rheumatic heart disease, going to do an aortogram. He saw at the last moment, the tip of his catheter dipped into the right coronary artery. He power injected. Patient went into ventricular fibrillation, but he saw the right coronary artery. And he said, oh my God, I can see the coronary arteries. And he actually was a pediatric cardiologist who invented coronary angiography. And then everyone knows who this is. Andreas Brunsig did the first balloon angioplasty in 1977. And the first coronary stent was introduced in 1989. And then in 2002, this man here, Alain Cribier, was the first to implant a percutaneous valve in a patient with severe aortic stenosis, 2002. Unfortunately, he passed away, I believe, just last month. The major advances in interventional cardiology over the past 20 years, I would argue, have been in the area of structural heart disease. And today we're going to talk a little bit about tricuspid regurgitation, chronic tricuspid regurgitation. These are the key points that I want everyone to get from this lecture, and I distributed those by email. First, I think it's important to understand just how common tricuspid regurgitation is. Detected in 82% of men, 85% of women. It's seen very commonly, and it's seen more commonly as we age in patients who have comorbid conditions and underlying heart disease. Now, just as we can with mitral valve, we can classify the tricuspid valve chronic regurgitation into 2 classes, that primary tricuspid regurgitation being that due to intrinsic disease of the valve itself. I'm not going to go through all these disorders, you should know them. But one aspect I do want to mention is the impact of pacemaker leads on tricuspid regurgitation. Here you see patients who have received pacemakers and had assessment of their tricuspid regurgitation both before and after their pacemaker. And you can see here in this portion of the curve, you can see, particularly with 2+ and greater, that it definitely increases in patients who have a pacemaker lead. Not only that, but on the right panel, you'll see that not only do they have tricuspid regurgitation, but severe tricuspid regurgitation, whether you have a pacemaker lead or not, is associated with worse clinical outcomes. I have tried to raise a voice on the importance of pacemaker lead interaction with the tricuspid valve, and I've tried to lead an initiative to try and redefine how we look at pacemaker interaction with the tricuspid valve, and this is an ongoing thing that we're working on. Secondary tricuspid regurgitation, of course, is due to left-sided disease, intrinsic pulmonary vascular disease, or right-sided disease. And the valve itself is normal in structure, and it's really just secondary due to annular dilatation and malcoaptation. So echo really is our guide when it comes to assessing the tricuspid valve. You can distinguish, primary versus secondary, the role of left-sided disease. We characterize tricuspid regurgitation as well as its hemodynamic consequences. And I think most of you are aware that the classification scheme for tricuspid regurgitation has been changed because it was felt that mild, moderate, and severe were not adequate to describe tricuspid regurgitation. But now 2 additional classifications, massive and torrential, which have their own specific definitions in terms of vena contracta and effective regurgitation orifice area, and so on. And these are not arbitrary definitions. Patients who have massive and torrential tricuspid regurgitation have more admissions for heart failure, and they have increased mortality compared to people who have lesser degrees of tricuspid regurgitation. And what is the impact of isolated TR? It's not a benign disease as we once thought it was. Here's a study that was done, retrospective observational study of 353 patients who have isolated TR, not a lot of other medical problems. And they looked at heart failure and cardiac death. And indeed, what you see here is that survival in patients with isolated tricuspid regurgitation correlates well with increasing effective regurgitant orifice area. And cardiac events as well increased with effective regurgitant orifice area. So I think we're becoming aware now that chronic TR is not the benign entity that we once thought it was. And the guidelines for tricuspid regurgitation are really not well developed. If you look at the bottom in terms of medical therapy, we're really only one thing that has been shown to be effective in symptomatic improvement, and that's diuretics. We don't have a lot of other therapeutic options for patients with chronic TR. So we have been looking hard for alternatives. If you look at the treatments for chronic TR, almost all of them are surgical. In fact, they all are surgical. And with surgery, we see that there is an increased mortality. There's a fairly high price tag for patients who go to surgery for isolated tricuspid regurgitation. Depending on the study you look at, anywhere from 30%, 40% mortality. So it carries a significant price tag. So we have been looking hard for alternative treatments for chronic TR that don't involve surgery and more effective than medication. If you look at the predictors for bad outcome after surgery, they are the usual things: older people, worse heart failure, liver disease, anemia, and renal failure. And I think the key thing is why surgical mortality is high is because I think patients are referred for surgery too late. They are referred for surgery when their right ventricle is shot and they have severe TR, severe RV dysfunction. And at that point, surgical salvage is really difficult. It's going to carry a high mortality. If we send these patients a little bit earlier, perhaps the surgical data would look better. So most of tricuspid regurgitation really goes untreated. I think primary care doctors really manage this medically and don't refer patients until it's really late. Only a small percentage of patients with chronic TR ever get any form of specific treatment. And the current status of tricuspid valve disease as it exists today is that it's undertreated. It's very prevalent. and as I showed you, impacts adversely on survival if left untreated. TR does not reliably improve after surgery for left-sided lesions, and most patients who go to surgery will have some sort of repair done on their tricuspid valve when they go to surgery. And it may actually worsen. Reoperation for severe tricuspid regurgitation is associated with increased mortality, as I've shown. As I've said, the guidelines show that historically most of the treatments are surgical, and options are very limited for patients with underlying comorbidities like pulmonary hypertension and RV dysfunction. And as I showed you, medical therapy is quite limited in really just diuretics. So we've been looking for alternatives. There have been a lot of devices which have been studied to treat chronic regurgitation. Some of them have looked at direct suture annuloplasty, ring annuloplasty done percutaneously, coaptation enhancements, and valve replacements. The first two, and all of these are in various forms of study. I'm not going to talk about all of these things. I'm just going to talk about a few which I feel have potential for widespread rolling out to the general interventional public and to the general patient population. So I'm going to focus on those which I think have real potential. And one of these is going to be the TriClip. So I'm going to talk a little bit about the TriLuminate trial, which is completed and published. And just to review a little bit about what TriClip is, it's a clip system, much in the way that was developed for the mitral valve, and it's been specially designed for delivery on the tricuspid valve. There's a steerable guide, and then you have a clip delivery system, which allows you to steer your way over the leaflets. The TriLuminate trial was 450 patients to evaluate the safety and efficacy of TriClip in improving clinical outcomes in symptomatic patients with severe tricuspid regurgitation. There was a randomized arm and a single arm. The randomized arm looked at the composite of mortality, tricuspid valve surgery, heart failure, and quality of life at 12 months. There were a bunch of secondary endpoints. Well, this was published last year, and you can see it met its efficacy and safety endpoints very nicely. The efficacy endpoint was based mainly on improvement in symptoms and reduced heart failure admissions. And if you look in at the data, the correlation of improvement in symptoms correlated very well with the reduction in tricuspid regurgitation. Here you see in this particular bar that the particular increase in patient wellness correlated with a greater than 2-grade decrease in the severity of the tricuspid regurgitation. And on the right, you see that most of the patients had significant improvement in their regurgitation after their TriClip. I think one of the main points to come out of this trial was that it's not a mortality trial. Treating patients with chronic TR does not necessarily give you a mortality benefit. What it does is give you improvement in symptoms and reduced admissions for hospital for heart failure. And you don't have to completely eliminate the tricuspid regurgitation to get that real clinical result. I think this data shows that if you can decrease the TR by 2 grades, you can take massive or torrential and go to severe, and they still get significant clinical benefit. You can't compare this to surgery where they put in a valve and have no residual TR post-operative. This is a procedure to palliate the patient, to improve their symptoms, reduce their admissions to heart failure. It's not a mortality benefit. Here we see at 2 years, the TriClip results are quite durable. So in terms of improvement in their symptoms, in terms of heart failure, and improvement in their TR grade, quite durable out at 2 years. And there's even favorable remodeling in terms of the TAPC increasing over time. You can see it out at 2 years. So improvement in symptoms, reduced heart failure admissions, favorable remodeling of the right ventricle are features of the TriClip and the TriLuminate study. So I thought I would throw in a couple cases here just to show you kind of what we're dealing with. This is a 76-year-old woman, male, with multiple comorbidities. He presented with severe New York Heart Association class 3-4 heart failure. You can see his echo here. I've labeled the chambers in case you're very tired and you can't recognize them. You see the right atrium, you see the right ventricle very dilated. And you see what would probably be considered massive TR. So the patient was enrolled in Triluminate trial. And just to remind everyone, this trial allows you to put a clip on there's on two of the leaflets, usually involving a septal, anterior, septal, posterior. And oftentimes you need to put in more than one clip. Here's an example of what it looks fluoroscopically with the clip attached to the tricuspid valve and then released. And this is what it looks like after it's been deployed. And here we are post-procedure. You can see the degree of tricuspid regurgitation is markedly improved. Regurgitation is almost gone just with one clip. His shortness of breath resolved. He was sent home and continues to do well even to this day. So this is what we can do with the tricuspid clip. Now, I don't know if I want to remind everyone that tricuspid clip was just FDA approved a couple of days ago, I believe 2 days ago. So we are about to enter a new phase of treatment where we can treat these patients commercially. So that'll lead to greater availability since patients won't have to satisfy all the inclusion criteria. In the spirit of equipoise, there is a second device which is out there, which operates the same way, and it's called Pascal device. Pascal device also is being studied on the tricuspid valve. It's earlier in the regulatory process, but it works in a very similar way. I'm not going to really talk about it that much, except to show you that there is an early feasibility study that was completed and published, and it shows results very similar to that seen with the TriClip. So I anticipate that this device too will be FDA approved at some point in the not too distant future. So everyone hoped that percutaneous valve for the mitral and the tricuspid position would be just as successful as it was for severe aortic stenosis. Because, aortic stenosis and TAVR has become ingrained into our society. There are more TAVRs performed in this country, in fact, worldwide, than there are surgical aortic valve replacements. So I think the thinking was that we'd be able to translate this technology to the other valve positions like the mitral tricuspid. That hasn't proved so easy, and there's a lot of reasons for that. What are the problems facing us as we develop percutaneous valve replacement platform for the tricuspid space? Well, tricuspid valve is a complex structure. I'm not going to go through all of this, but suffice it to say that it has an annulus. There are papillary muscles. There are cords. And the opening and closing of the tricuspid valve is not a passive process. It's an active process. Whereas the aortic valve is really just a door that opens and closes in response to a pressure gradient. So the tricuspid valve is much more complex. And it also, the annulus, unlike the aortic valve, which is essentially a planar structure, the annulus of the tricuspid valve is not planar. It's more of a saddle shape. And all of this presents unique difficulties for designing a percutaneous valve replacement platform. The annulus of the tricuspid valve is much larger than the other valve, 7 to 9 square centimeters. The mitral is something like 4 to 6. The valve, when it's diseased, is usually not calcified. Unlike the aortic valve, when you implant a TAVR valve, you rely on that calcium to anchor the valve. Well, that's not the case with the tricuspid valve. And most of the time, at least in functional TR, there's an ongoing process which continues unabated. So the ventricle, the annulus, may continue to dilate over time. Leaflets of the tricuspid valve are much thinner, much more pliable than the aortic valve or the mitral valve. And they are more fragile and prone to injury when you manipulate them. There is a very dense chordal structure in the right ventricle. even more than in the left side, in the left ventricle, and the cord-free zone is actually quite small and difficult to navigate. There is proximity to the right coronary artery and the AV node. Conduction disturbances are common. And most importantly, procedural imaging for the tricuspid valve is exceedingly difficult. TEE often is challenging to visualize the tricuspid valve leaflets in multiple views. We often have to combine it with intracardiac echo, which can reliably give you 1 or 2 views, so-called ICE-T. So this is what we often do with tricuspid interventions. We use a combination of TEE and ICE to help visualize the valve for procedural intervention. So there's a lot of difficulties in developing a percutaneous valve platform, which would be successful in the tricuspid position. But efforts are ongoing, and the EVOQUE valve, which was just approved too on February 2nd of this year, is one such platform which has been tested, tried, and evaluated in clinical study, and as I said, approved. It's designed for transfemoral delivery, comes in 3 sizes, I think soon to be a 4th. And it has a steerable delivery system, a tri-leaflet bovine pericardial valve with a nitinol frame and a fabric skirt and 9 anchors. And you have to, when you deploy it, you have to engage the leaflets. So it's important to have some degree of leaflet integrity when you deploy this valve, as you can see here. But, you know, once you get it in place, putting it in is not, it's actually quite quick once you get everything steered the way you want it. And there it is being deployed. Right there.
So once that's deployed, can you recapture that?
Yes, you can recapture it up to a point, right? The EVOQUE valve has been studied in two studies. One is an early feasibility study, which I'm showing here on this slide, which is 30 days with 56 patients with greater or equal to moderate TR on medications, a bunch of exclusion criteria, and I've tried to lay out those important ones there. And you can see that the success was very high. I've defined device success, procedural success, and clinical success, as you see at the bottom. Important is clinical success, which is procedural success. I mean, device deployment with no leak and no major adverse events at 30 days. And you can see in the right panel that the valve works very effectively. Once you put it in, there is no tricuspid regurgitation. It eliminates it. And one of the problems with TEER is that you're always left with some degree of regurgitation. So this is a different approach. One can argue which is more effective. This has its own complexities. Here you can see the results. You can see the composite major adverse event rate is significant, 26%. But when you analyze that, really it's just, these are bleeding problems. These are bleeding complications more than anything else. And then you look at the TR severity, as I said, virtually eliminated. New York Heart Association class, where it was 3 and 4, is now 1 and 2. The 6-minute walk improves, as does the KCCQ. So by all metrics, patients are better after they get their valve and eliminate tricuspid regurgitation.
They avoided severe artery dysfunction.
Yes.
If that valve is placed in patients and you underestimate the degree of artery dysfunction, is there an incidence of artery failure?
Yeah, I mean, in the trials, these patients were not included, right? So, but now as it's commercially available, you know, you're going to find out. I would think that if you put a valve in someone who has marginal artery function, it can certainly not be well tolerated, precipitate acute right heart failure.
I was going to ask this question afterwards, since we're talking about it. I mean, there's great challenges in evaluating the function of these patients, right?
Yes.
So things, I think Vaughn is RVEF, which is actually the meeting was a patient with severe TR. In other words, you know, on the positive side, meaning the RV
function. Obviously, if the RBF is bad, and you have severe TR, you know the RB is bad, but the RBEF is normal, that doesn't mean the intrinsic function is normal as well.
True.
A lot of the trials have relied on TAPSI, which has also lots of issues in severe TR.
Yes.
So there's now a push to sort of use some of these one of the newer methods like, you know, RB strain, which
Yes.
is been nicely validated in patients with severe TR, and we should be switching. We have been switching with that lab gradually to use some of these methods. But clearly, what we have been doing for years, which is just kind of qualitatively assessing RB, is completely insufficient in this patient. We are going to end up with what Peter talked about, which is acute RB failure. These people with torrential TR and on both borderline RB function to begin with.
Yeah, well, once it's commercialized and it's out there, people are going to be using it in a variety of different circumstances. You'll see some of that. And I do agree, it's that we need to develop new parameters for evaluating intrinsic RB function. Sure.
Yeah.
Because CBD constantly explain in this attack and which is not especially if you go completely based on the
But even for screening things like the RB strain, they're actually very easy to do. Something to see the RB, it's a one-click thing, and you do it as quite routine.
These are the one-year outcomes. And this is the data that probably led to the FDA approval. This was 176 patients. Same kind of look to the study. You can see I gave you the important baseline variables. It's a fairly sick population. 32% had pacemakers, 92% had atrial fibrillation, 75% class 3 and 4. So it's a pretty sick population. And once again, I gave you the data. You see clinical success, 77.1%. The reason it's lower is because of the major adverse events, which again are mainly bleeding, which is something that we overcome as we get better with the procedure. I will say the permanent pacemaker rate is about 14.7%, which if you were looking at the TAVR side of things, you would find that unacceptable, but it is 14.7%, probably because of its proximity medially to the conduction system. So I think this is something that we have to study closely. But the results at 1 year are very durable and maintained over that seen at 30 days. And there's significant improvement in hospitalization for heart failure. I thought that was worth pointing. So very positive data on the Evoke valve, which led to its FDA approval. And we're going to start seeing a lot more usage of this as well as the TriClip over the ensuing months. In the spirit of equipoise, there's a second valve platform, which is out there from Medtronic, the Intrepid valve, which also I'm showing it was originally developed for a mitral application, but is being adapted to the tricuspid side. There will be a clinical trial using the Intrepid valve in the tricuspid position in the next year or two. I hope that we'll be able to participate in that. It has a different sort of delivery system, which you see here. But I think I like the design of this valve, and I'm hopeful that this will prove successful, not only in the mitral position in the Apollo trial, but in the tricuspid position as well. So here's another example case of a 79-year-old who has lots of comorbidities, but she has, torrential TR, and she has a lot of underlying problems. She does have a pacemaker, and she was transferred from an outside hospital with severe heart failure. She's had recurrent admissions for right-sided heart failure. She's had to have recurrent paracentesis. She is inotrope dependent, and transthoracic echo showed knee up to 45% with mild MR and torrential TR. Here we see a view of that. There is complete non-coaptation of the tricuspid leaflets and torrential tricuspid regurgitation. So there's no coaptation whatsoever. So a clip is not going to work. She was very debilitated and frail. Surgery was out of the question. Here's a dense continuous wave signal suggesting TR. You can see hepatic vein flow, all very consistent. So it was really a dilemma what to do with this woman. So we elected to do a cable valve implant. What we're going to do is deploy a TAVR valve in the IVC so that there was just unidirectional flow. Problem with these patients is that the IVCs in patients with chronic TR tend to be very large, and they often exceed the diameter, the applicability of current commercially available valve platforms. So our plan was to get some measurements on the IVC, and then to create a rail, a wire rail from the internal jugular out the femoral vein. So we have one continuous wire. We snared it, pulled it out the femoral vein in the leg. And we put a wire in the hepatic vein as a marker. And we are going to deploy a biliary stent here at the IVC-RA junction. And we deploy that stent, and then we're going to put a TAVR valve inside. The biliary stent serves as a scaffolding to allow you to implant that valve and give you a little more tolerance in terms of diameter. So we implanted that valve, as you can see here, just as you would any TAVR valve. And you can see it really did adhere well to the stent. And here we see an injection showing really unidirectional flow and no regurgitation. And here's her cath numbers before and after the procedure, markedly improved. And her symptoms improved. She improved dramatically. Our renal function improved. She was discharged home on warfarin, and she did well. Now, obviously, by not treating the SVC portion, one has concern that maybe they would develop SVC syndrome or something like that, but that didn't happen. Most of the problem was in the IVC. So this concept, this cable valve implant, is what set the stage for the trick valve technology. Trick valve technology is a two-valve treatment for a single valve problem. And the interesting thing about it is that it doesn't treat the actual valve itself. So the pathology of the valve is untreated. You're treating the hemodynamic effects of the tricuspid regurgitation by deploying a valve in the SVC and a second valve in the IVC. And here's the design of the two valves, one for the SVC on the right and the IVC on the left. They have a short skirt, nitinol composition, and a bovine pericardium. And here's the specs. You can see the design. So here's a case, and you can see the valve being deployed in the SVC. It has a three-component design to ensure stability. And then you see the valve deployed in the IVC. This technology is waiting approval by the FDA for a trial. The technology is there, but the FDA has to approve the trial, clinical trial, and we here will certainly be part of that trial. I'm excited about this technology because it allows us to palliate treatment patients who cannot be treated by any other technology. For example, if you got TR, you don't have coaptation of the leaflets, they're anatomically not suitable for percutaneous valve, they're not surgical candidates, then this will be the niche for this kind of technology. You can also, work around pacemaker leads, just.
You still end up gelling the lead.
Yes.
Yeah, it's not, I know that's, I'm not, you're just gelling it in a different place.
You're jailing it in a different place, not inside the heart.
Yeah.
You're right.
It's a nice option if you don't have
It's not perfect. This is a palliative procedure. I see.
And the stability, one of the things we've seen with venous stenting in general, of course, we've got a few cases here where stents have migrated, venous stents have been placed in the leg, and even one that we recently had an SVC stent that was placed as a palliative therapy in somebody that I think Nathan's going to present in the next couple of weeks that looked like it migrated. How this design is.
The design is meant to prevent that, especially the SVC one has this really engages the SVC strongly. I don't think migration is going to be a big issue unless, it's not put in correctly.
Yeah.
So there are a couple other treatments we have available to us, which I thought I would throw out at this point. Here's an example of a patient, a 60-year-old woman who has rheumatic heart disease, and she presented with worsening shortness of breath. She had had prior surgery, an open mitral commissurotomy, a mechanical MVR, and she had a tricuspid annuloplasty, and now has severe TR after receiving an Edwards ring 28 millimeter MC3 years ago. Class 3 heart failure. Here's her right heart pressures, very elevated, right chambers. And here's her fluoro. And you can see the ring, okay, right here. So there was a lot of discussion about what to do with this woman. There was no FDA approved treatment in this case. So what we were going to try was to implant a TAVR valve inside that ring. So I don't know what you all know about annuloplasty. I used to know nothing. But doing the work that I do, I've really begun to learn about these rings that surgeons put in the mitral and the tricuspid space. There are different types of rings. There are complete rings, there are partial rings, there are circular, elliptical, there are rigid, semi-rigid, so all these different kinds of rings. And how does the surgeon choose which ring to use? It's amazing that it's almost arbitrary. So these are the different kinds of rings: circular, C-shaped, planar, saddle-shaped, rigid, semi-rigid, flexible. So for percutaneous valve work, you'd like to see a semi-rigid ring, one that stretches so that when you put the valve in, it can stretch. The rigid rings are not going to move. Either it conforms or it doesn't conform. But the semi-rigid and the flexible will stretch. Those are the kind you like for percutaneous valve interventions. This is the valve, the ring that was put into this particular patient. They're all, most of them in the tricuspid position are C-shaped because they try to avoid the conduction system. And we did this from the right IJ approach. Plan was to put a 29 millimeter valve inside that ring. Here's the intraprocedural TEE showing the tricuspid regurgitation. And here we are implanting the valve inside the ring. Don't confuse it with the St. Jude valve that's there, but you can see the ring there. You see it right here. And we're implanting the valve right inside that ring. Right. You got to be very careful that you get it just right. Otherwise, the skirt that lines the valve, you'll miss, and then you'll have a lot of leak. And here we are with the valve deployed inside that ring. And here we are afterwards. Really nice result, no residual TR. So you can put a commercial valve inside a previously placed annuloplasty ring in the mitral or the tricuspid position. Now, these are not really FDA approved, they're off-label applications. Here's day one, looks good. Follow-up, patient did great. New York Heart Association class 1. Then here's an example of a patient who got a bioprosthesis in the tricuspid position. 37 years old, history of congenital heart disease, blade lactocytic shunt, right ventricular infundibulectomy at 16. So she's had a bunch of prior cardiac surgery. She has a bioprosthesis in the tricuspid position, 33 millimeter epic. So echo was done, showed a gradient of 12 with severe tricuspid regurgitation. And here we are implanting a valve inside that bioprosthesis. Now, unfortunately, with this one, the frame of the bioprosthesis is not all that visible. You got to look really hard to see it. I'm standing right here and I can barely see it. But you can see us implanting the valve right inside the previous bioprosthesis and now deploying the valve. Just like that. There it is. And we're injecting contrast into the right ventricle, no TR. She did well, went home the next day. So in conclusion, near the end here, the percutaneous therapies for tricuspid valve disease are going to continue to expand over the next 5 to 10 years. Newer non-surgical treatments will probably replace isolated tricuspid valve surgery as we move forward. Catheter-based repair and replacement platforms will become routine part of our toolkit. So at the end, I put together some initial thoughts of what this is going to look. So for the practitioner, anyone who has greater than or equal to moderate to severe symptomatic TR, you refer to your heart failure structural heart disease team for medical optimization, alteration of medical therapy, diuretics, whatever. And then if they have persistent symptoms, you can consider surgery. It still has a role for maybe low-risk patients, but it's not to say that newer, more advanced catheter-based options can't be considered for even low-risk patients. Certainly, if they're higher risk, you want to consider non-surgical options. So this is my personal thoughts on this. Anyone who has persistent symptoms after medical optimization should have a TEE and a CT. If they have a pacemaker and they have lead impingement, then we ask our electrophysiologist colleagues to see what could be done. Obviously, if a lead has been in for 15 years, it's not coming in. Could something be done? In some instances, could the lead be removed? Could you use a leadless pacemaker, something like that? So you have to, in this particular space, working closely with our electrophysiology colleagues is really essential. As well as working with the other members of the multidisciplinary team, cardiac surgery, heart failure, everyone. If they do not have any lead interaction with the valve, but still have severe tricuspid regurgitation, you have to think about their RV function or whether they have pulmonary hypertension. If they do have severe RV dysfunction, pulmonary hypertension, like we were talking about, then maybe they would be a good candidate for transcatheter edge-to-edge repair, or else maybe a cable implant if the protocol gets approved. If they have preserved RV function, no pulmonary hypertension, and they have suitable anatomy due to a whole variety of anatomic factors which we have to evaluate, you could consider the Evoke valve, which is now commercially available. And if they're unsuitable, then we have options of TEER or the cable implant on a protocol when it gets released. So this is kind of where I think we stand right now with this area. I hope this has given you some clarity to a really muddy area up to this point. So with that, I'm going to stop here. And if there's any questions, I'll be happy to entertain them. After all, we all are cardiologists. Yes.
I think one of the things that I was struggling with, among many things I've struggled with this disease, is with the motor dysfunction and how I define the dysfunction. Because, we refer people to hepatology, they sort of have an often fairly nebulous conclusion about the state of the liver. You know, it's either no fibrosis or fibrosis. Liver water content is a routine analyze, which is probably what you really want to know in severe TR. I mean, obviously, if they have advanced cirrhosis, that's a different issue.
Right.
We've always been wondering, I don't know if any of my MRI colleagues are on as well, we've been talking about the assessment of liver, our cardiac MRIs that we do all the time, we sort of ignore the liver a little bit, but it's there. We can assess water content and iron content with MRI reasonably easily, but I don't know what to do with it. But again, it's clear that right up front ultrasound and ALT, AST, and albumin probably doesn't give you a complete picture of liver health. What are your thoughts on that? What do you do with the liver, since that's the most proximal influence?
You know, if someone has liver dysfunction and severe TR, RV dysfunction, one has to presume there's some relationship. So from an interventional standpoint, reducing that will help the liver heal.
So I think what you're saying is using it as a using a better indicator as a trigger to do something. I think the liver is.
Oh, I don't know.
I think that the point here, and we see this all the time, is that the surgeons wait too long and then they end up with huge bleeding complications.
Right.
Because there are coagulation issues. I think Eli is saying, is there a way for that to trigger the intervention? And it's otherwise a large pool of TR patients that most of them are not sure. You know, you will see a lot of TR.
So, you know, we're going to learn a lot now. We have FDA approval of these things, and there's going to be commercialization. You know, the enrollment in the trials is fairly rigid, you know, but now we have an opportunity to do this in a nuanced way and learn as we move forward. And what you're suggesting is very reasonable. I mean, it wasn't part of any of the trials, but why not?
You know, we also have lots of data as we're moving to EPIC. It's going to be potentially a little bit more searchable.
Sure.
But these people get a lot of imaging, which is a lot of labs, a lot of MRs
Sure.
and CTs, and we could probably mine this.
Yeah, I mean, there's going to be a lot of opportunity here in the next few years, particularly when it comes to our heart failure colleagues, electrophysiology, all of us will work together in this new space.
So Warren had an online question on the same topic that Eli just brought up is, are there any data on, I have an echo here, on imaging and whether or not imaging actually changes, you know, the time of procedure and how it helps there. And then Rob had a question on cost effectiveness.
You know, the liver, I haven't thought about the liver that much. I just saw liver dysfunction as a further proof that it was important that I move and treat. In terms of cost effectiveness, the Vogue valve is quite expensive. The margins, the returns are going to be quite narrow on the Vogue valve. It costs more than a TAVR valve. If you say a TAVR valve costs somewhere around $32,000, I believe the Evoque valve comes in around $43,000. And so the margins are going to be very narrow. So, but you have to compare the cost effectiveness to this versus repeated admissions for heart failure. So it's not a simple question.
Now that you just mentioned the recurrent admissions to heart failure, so by eliminating it was hard to show that radical primary endpoint was driven by like cases Q questionnaire from the life even the able, you know, it's been hard to show, although I wonder what you think why has been the case on increased hospitalization, whether it's time follow-up, right? Because you don't have like a year follow-up.
Yeah, I think
Later, but constant patients say, hey, these are the hospitalizations going through based on the current trials, which we have to do from health and that. But you feel like what for everyone, so if they feel better, I think
if they feel better, then they come to the hospital less. You know, as Peter pointed out, these patients are referred very late. We get to see these patients when they're in refractory right heart failure. It would be nice to get them a little earlier where there's more therapeutic options And hopefully now with commercial approval of all these new therapies, we will see them a little sooner and perhaps can intervene a little earlier. Any other questions?
Cliff, can you just say a few words on carcinoid heart disease and what options might be available for that population?
Well, carcinoid leads to obstruction. So there's not only of the tricuspid valve, but the pulmonic valve as well. If it's pure stenosis and their prognosis is good, could be considered for evoke valve. Now that it's been commercially approved. I don't think the trial itself only enrolled patients with regurgitation, but now that it's commercially available, and be able to do whatever we want. I don't know if it's ever been done. I certainly haven't done it, but certainly it's something that could be done. If it's stenosis and it's very narrow, you can even put in, if it's calcific, you can put in one of the commercially available TAVR valves too. I haven't really seen a case of severe stenosis from carcinoid in a few years. If someone has one, I'd be happy to evaluate.
All right.
Okay, well, thank you all very much.
Thank you,
Nice
Cliff.
to see you out there.